Good afternoon, everyone, and welcome to our August seminar, which is a collaborative presentation of the Federation for Children with Special Needs, the Recruitment Training and Support Center, and MassFamily Voices. My name is Pat Nemia, and I'm the Program Coordinator for MassFamily Voices, Family to Family Health Information Center. Today's webinar is Navigating CBHI Services. It is presented by Laura Conrad, MSW. Laura is the Program Manager for Children's Behavioral Health in the Office of Behavioral Health at MassHealth. Laura oversees the implementation of services of the Children's Behavioral Health Initiative and applied behavior analysis within the MassHealth Managed Care Entities and serves as the Office of Behavioral Health's liaison with the child serving agencies in the Commonwealth. During the webinar, please type your questions in the toolbox and we will answer them. We will leave time and answer them at the end of the webinar. Past webinars are archived on the RTSC website and MassFamily Voices website, along with many other resources on trauma, learning, education, and health issues that impact students in child welfare and impact children and students with special health care needs. Welcome, Laura.
Thank you. Thank you for having me today. So I just started, this presentation is on, we're going to talk a little bit about MassHealth eligibility and what behavioral health benefits are available for members that are 0 to 20. I'll just click the screen. Oh, there we go. Sorry, a little technical understanding. So I first just want to go over, there are different types of MassHealth. Similar, if folks may have commercial insurance, there's, PPOCs, there are HMOs. So within MassHealth, there are different types of insurances. The most common for kids are MassHealth Standard, which has majority of our kids are in MassHealth Standard. Common Health, with kids with disabilities are in Common Health, and Family Assistance. Again, majority of kids fall into the standard Common Health categories, and then there's a smallest percentage within Family Assistance. There are some other insurances that are out there, or types of MassHealth insurance, but I really am not going to focus on those today. Again, 85% of kids are within the standard and Common Health insurance, and those are for, again, members that are under 21. I want to talk a little bit about Common Health, and for kids that are eligible for Common Health is determined by a child have a disability, and so I do want to clarify, as people think of disability as a physical health disability, children actually may qualify for Common Health if they have 12 months of a chronic condition, and that chronic condition can be related to a mental health or behavioral health condition, such as ADHD, such as a conduct disorder. So I encourage people to apply for Common Health. You would fill out a regular MassHealth application and then fill out the disability supplement. For Common Health, there could be a premium that people have to pay at different points of times, because we have a lot of kids that are actually on commercial health insurance that apply to get Common Health because of the behavioral health benefits offered through MassHealth. Keep going. We talked a little bit about that. This is just information about the phone numbers to call about and the websites to go to about Common Health and the MassHealth application and the disability supplement form. I also encourage families to think about is if a child has MassHealth Standard, and at some point the family may get commercial insurance or coverage at some time, and then you would drop, you probably would not be eligible for the MassHealth Standard. So I still encourage families, if you have a child with a disability, which could be a mental health disability, to apply for Common Health, because that way you could still have the MassHealth benefits. So we just talked about, and so I do want to say for Common Health, those for kids that have commercial insurance, that have Common Health as the secondary insurance, that benefit is administered through MBHP. And what that benefit also does for the commercial members, it entitles them to a variety of behavioral health benefits that are not available within the commercial system, and it also covers co-pays and deductibles. So for every doctor's visit that you have, there sometimes is a copay or a deductible. It would cover those. And for also pharmacy costs, deductibles, it would cover those. So that's also another reason to get the Commonwealth, the disability coverage. And again, here's some more information of where to go. Really encourage people to apply online through to go online to the MassHealth Connector. There are ways to get help through certified application counselors or navigators at community health centers. Hospitals will help people navigate that. But you can send paper application, but that's really not the preferred method. The preferred method nowadays is the online applications. And the disability supplement actually is a paper application, but the initial is through, the initial MassHealth application is preferred is online. So now I just want to spend most of the time actually talking about the behavioral health services that are available for kids at MassHealth. So this slide really kind of rolls it all up of what all those behavioral health services are, and then it lists on the right-hand side the actual type of coverage, because not every service is available depending on the type of coverage, such as family assistance is not as a robust coverage type as standard and common health. So again, if your child qualifies for family assistance and has a disability, I encourage you as a family to fill out that disability supplement so you can get the common health, the more robust coverage. So outpatient therapy is available, mobile crisis, structured outpatient addiction, which sometimes can be referred to as SOAP, in-home therapy, and ABA are behavioral health benefits that are covered by all three of the, if you will, coverage types. Intensive care coordination, family partner, in-home behavioral and therapeutic mentors. You need the more comprehensive benefits, standard and common health, to get those services. I'm going to spend some time talking about these services, but I did just want you to see these are all the behavioral health benefits that are available. And I would say all of these services, except for outpatient and ABA, are not available under majority of commercial health insurance plans. And all of the services are available as community-based intensive home-based services. So I want to spend some time now talking about the services. So the first service is one of our most intensive services, and it's called intensive care coordination. It uses a wraparound process. If you have common health, again, or standard, a child is eligible for intensive care coordination. The child does need to have an SED, which is a serious emotional disturbance. And this, what it does is there's a care coordinator that does an assessment, develops a care plan, and helps figure out kind of what related services would the child and family would benefit from, and they kind of monitor that process. The care coordination is delivered through master's or bachelor level staff. I will say this is a pretty intensive process, and typically what we see kids that are needing care coordination are kids that may be involved with schools, have had some hospitalizations, may be involved with other state agencies, and that family is needing some help kind of navigating the system and coordinating the system. Some little bit more, there is a process around kind of, it should be a family-driven process, and the family should be driving the care and helping develop the goals that are on that treatment plan. And there is also a real strong commitment to cultural competency within the wraparound and intensive care process. I will say the teams also, the process should be bringing everybody that's part of the child's team together at least once a month to kind of talk about where the treatment is, are the goals being met on the treatment plan, and are there services that, again, the child would benefit. There are the intensive care coordination is provided by a community service agency, a CSA. There are 32 of those CSAs statewide. They all cover a specific geographic area. There are 3 culturally competent CSAs, one that serves the African American population, one that serves the deaf and hard of hearing, and one that serves the Latino population. And I will talk about at the very end of some resources of where to find these services. The next service is family support and training, or what we typically refer to as a family partner. This is a one-to-one relationship with the parent of the child who has some mental health challenges. This is a parent that has raised a child with a serious emotional disturbance also, so they've kind of walked in the shoes of a parent. They provide coaching support to the parent of the youth with the needs. It can include coaching support, going to meetings, going to appointments. They typically, you see family partners, they may go to a prescriber if the child is on medication. They may go to an appointment with the prescriber with the parent to help coach the parent. They may also go to a school meeting with the parent to help coach the parent. And it could be they're going to, an outpatient therapist. Again, this service is delivered in the community and regularly goes to the family's home and meets with the parent and the youth at the family's home. This is one of our most anecdotally, what we hear a lot of positives around this is because parents appreciate that support and understanding from a parent that has walked in their shoes. To get a family partner, I do want to talk about this. You do need to have, you can't just go get a family partner by itself. You need to have either intensive care coordination, in-home therapy, which is IHT, or outpatient therapy. The next service is mobile crisis intervention. This is a short-term, face-to-face. If your child is in the middle of a mental health crisis, you can call mobile crisis. They come to the home 24/7, 7 days a week, and they will do the evaluation of your child at the home and can be available up to 7 days to help support the child in the home during that crisis period. They also would evaluate a child if they needed a higher or 24-hour level of care, such as hospital or CBAT. Really, I will say it's much better to keep a child at home than it is to take them to the emergency room for a crisis evaluation. So they will come to your home and do this, or they actually can go to a school or to a doctor's office. They can go anywhere. There are some community-based locations for mobile crisis that you could take your child to instead of an emergency room, but that is a little bit about mobile crisis. The next service is in-home behavioral service. I like to say this is kind of ABA light, if you're familiar with applied behavioral analysis. In-home behavioral service, again, is another service is similar to family partner that you would need outpatient in-home therapy or ICC. Sometimes you'll hear this referred to as a hub-dependent service. What they do is go in the home to do a functional behavioral assessment, develop a very specific behavioral support plan around how to help the child kind of decrease if there's kind of negative behaviors that are happening in the home, or increase behaviors such as routines, different type of things. But we see a lot of kids that are getting in-home behaviorals. There could be definitely some kids that are on the autism spectrum that are getting in-home behavioral, especially those higher functioning kids that need more intensive, a more intensive behavioral plan. And also we see kids that have some aggression or conduct disorders, people like to say, or defiancy. We see some of those kids that benefit, that get in-home behavioral and benefit from in-home behavioral. This is a two-person team model. There is a master's level clinician and there is a bachelor's level staff that works with the family too. This model, which is different than ABA, is much more works with the family as a whole and helps kind of coach the family and the parents around kind of routines, behavior plans, around routines and behavior plans. And again, all of these services are available for youth that are 0 to 20. So the next service is Therapeutic Mentoring. Again, it's another service that you need to have either outpatient, in-home therapy, or ICC, a hub-dependent service. Therapeutic mentoring is structured one-on-one mentoring with the child and the therapeutic mentor. They take the child in the community to kind of work on daily living, social skills, communication skills. It is therapeutic in nature. It is not a big brother or a big sister. There needs to be a goal in the treatment plan that is developed by, if you will, the outpatient therapist, the in-home therapist, the intensive care coordination. They need to develop a goal that the therapeutic mentors are working on. It is delivered, again, in the home and the community. Most of the time is spent one-on-one with that youth, whether that's in the community. It could be the child, for example, has some anxiety around being in the community, participating in sports or activities, and the therapeutic mentoring is trying to help around some of that anxiety. It could be the child is unsafe in the community and can dart and run and exhibits unsafe behavior, so the therapeutic mentor works with that child around developing safe behavior while in the community. And the therapeutic mentor is also communicating and working and touching base with the parent, but most of the service is provided one-on-one with that youth. The next service is in-home therapy. This is probably our biggest service or most utilized service of any of the CBHI services. This is intensive, home-based, if you will, family treatment. It is a two-team model. It is a master's level clinician and also a bachelor's level clinician. They work with the family, the youth, and the parent around the child's need. So they will go into the home. They can do family therapy, didactic family with both the child and the parent together, and they also will work with the child one-on-one and with the parent one-on-one. They help develop routine, work with the family, develop routines, they will work on trauma-related issues. It really depends on the youth. Typically, this service is more than once a week. It can be anywhere from a couple hours to more hours a week, depending on the needs of the family. But I do want to say, I think there's some confusion out there is, if a child can benefit from outpatient, the child really should be an outpatient, because this service is much more intensive than outpatient. And sometimes I think families come and they want in-home therapy, and then they realize it's possibly 2 or 3 times a week, multiple hours a week, and that's a lot. But depending on the need of the child and the family, there are lots of families out there that benefit from 2 to 3 times a week, multiple hours, could be multiple hours a day. This service is available 7 days a week, so the therapist actually can be coming Saturdays and Sundays, and it's available from 8 to 8. I say 8 to 8, but I know there are clinicians that go to families' homes at 6 o'clock in the morning to help kind of model routines to get the child up and ready and prepared for school or daycare or preschool, whatever it may be. They model the routines for the family and work with the family to how to put in place that routine. Okay, so I do want to talk a little bit about the resources that are available. So the Health Connector is about applying for MassHealth and the application. There is a great resource out there about the difference. I didn't really talk about ABA, but ABA is Applied Behavioral Analysis. Is a service that's available for children that have autism spectrum disorder, again, 0 to 20. There's a great resource out there, and this link points to that really looks at the difference between what ABA is and what CBHI is. MassHealth did not develop it, someone else, so I will give them credit, but it's a really nice resource talking about the differences in the two. The disability form, the link there is there for that. And then for finding CBHI services, I think I do want to talk about that, is sometimes people don't know where to go to find the CBHI services. This next website we call MABA is a resource, an online kind of search database where you just go in as a guest, you log in as a guest. You actually don't even need to log on, you just hit guest, and you can put in your zip code, and you can put in the service level. There's a drop-down menu for the type of different services. So you can put in intensive care coordination and put your zip code, and it'll show you all the CSAs, the CSA that's in your catchment area, and the contact information of who to call. Same thing for in-home therapy, IHT. You put IHT in, it'll show you all the IHTs that are in your catchment area and who's within a certain distance of your catchment area. It'll also show you, which is the reality, and I do want to be transparent, is some of these services have wait list, and providers need to keep a wait list and be calling families to touch base about that wait list. But it'll also show you providers, say for in-home therapy, IHT, that have immediate openings, and then some that may have an opening in a couple weeks from now. The resource also, the database, the online database, is updated at least once a week by all providers. And some of the providers actually put in if they have certain language capacities and that type of information. So I encourage people to use this website. This website is, this resource is for all MassHealth plan types. And I mean Common Health and Standard and Family Assistance, but I also mean also the MCO and ACO that you are in. All of those providers, no matter which ACO or an MCO, use this MABA website. Use the MABA website to collect their information. So that is I would tell people is where they should go to first. And I think that's the end of my slide. So we've covered a lot of information. CBHI sometimes can be confusing to parents of where to go and what service do I want to go to first. When you call a CBHI provider, especially IHT and intensive care coordination, a lot of them have kind of intake coordinators, and they will help actually, if it's the parent really should be calling. They will help kind of the parent walk through kind of what are the challenges, where are the needs, and what is the best service to help triage you to kind of pinpoint you in the right direction, because it can be complicated or confusing. You know, what service do I need and want? I will say some of, just for clarification, people understand, in-home therapy, IHT, is an intensive home-based clinical intervention in which it starts, you know, immediately providing that intensive clinical intervention. Where intensive care coordination, the IACC, is a care coordination service, and it is a clinical service, but it's not a clinical intervention that in-home therapy is. So I would encourage people to call the providers, and if you're unsure of what service you think you would benefit from, if you call, they'll help you kind of walk through and triage some of that. And like I said, the what we call the hub-dependent services, family partner, therapeutic mentoring, in-home behavioral service, you actually, as a parent, can't make a referral directly to those organizations. You have to have one of the hub services, outpatient, IHT, and ICC, to make a referral. You can call the TM provider, and they can kind of help you figure out who your hub is if you're confused whether you have one or not, and they can help your hub figure out, your outpatient therapists figure out what documents they need to make that referral. But typically they will not accept a referral, those hub dependent providers will not accept a referral straight from a family. So I covered a lot of information, so at this point I will turn it over to some questions that people may have.
So I think there's a couple of questions about actual health coverage and clarifying. So one of the questions was about children in DCF care, and do they get a particular type of MassHealth? Do they have to go through an application process?
So all kids that DCF has custody of, so there's a difference. There's one thing if you have an open case through DCF, but the parents still have custody, versus kids that are in DCF custody, such as kids that are in foster care and kids that are in group care. They all have MassHealth Standard, and they're automatically assigned MassHealth Standard when DCF opens up that custody. So there's nothing a parent or family or foster parent would need to do, because they automatically have that MassHealth Standard coverage as long as DCF has custody of the child.
And MassHealth Standard covers all of these services?
MassHealth Standard is a comprehensive coverage type, and it covers all of these, yes.
And so the question comes in when children may be transitioning back into adoptive situations, or transitioning back to their family. What happens to that coverage then?
So it is a complicated, it can be a difficult transition, I will say that. For kids that were adopted through the department, through DCF. They actually have, through this adoption subsidy, they actually have MassHealth standard until they're 18, until they're at least 18. For kids that are transitioning back to their parents, I think this is where there needs to be a lot of conversation around that transition and what it's going to look like, because there are quite a few situations where the parents applied for MassHealth and the child would have MassHealth because the parents applied. But if that is not the case and they don't meet eligibility requirements for MassHealth, there needs to be a conversation of what services are going to look like when the child transitions back to the parent, and what commercial insurance the parent has, and what support is available through that commercial insurance, and what support is available through DCF and through their support and stabilization services. Because typically, and again, every case is different, and so the conversation should be happening with the DCF social worker and supervisor. Typically, when custody is relinquished back to the parents, that MassHealth is closed. That's not always the case, but that is majority of the cases. And so that's why there needs to be a conversation during that transition period to have a conversation of what it's going to look like.
And so just to clarify for someone, when you talk about Commonwealth, that's the group that has commercial insurance that could potentially not access any CBHI services unless they apply and get Commonwealth.
Right. If Commonwealth, so you could have kids that are on Commonwealth that have a disability that don't have commercial insurance, that their parents have applied, and now they're quote disabled, and so they have the Commonwealth. But there's a large percentage of those kids that actually have commercial insurance. Their parents have applied for Commonwealth to say their child is disabled, and they get assigned that Commonwealth. So in those DCF situations, that could happen. I will say there's required documentation to apply for Commonwealth of the disability. So a family may need some help kind of navigating that and helping with that process to get the Commonwealth. And that Commonwealth, again, benefit package is the same as standard, and all of the CBHI services are offered within the Commonwealth coverage type. And one thing I want to say is for Commonwealth, if a family has commercial insurance, and they're not eligible for MassHealth standard because of income, there potentially could be a premium or a dollar amount the family is required to pay for that Commonwealth, that secondary coverage. And that amount can range from a small amount to actually vary a lot, depending on their income. And so families just need to really think through what their costs are going to be monthly and what kind of benefits they need.
So there's another question surrounding comorbid diagnosis of autism spectrum disorder and of SED. And can a child have a primary diagnosis of autism spectrum disorder with a comorbid diagnosis of SED and be eligible for an ICC?
So for ICC, the primary diagnosis needs to be the SED. You can have a child that's on the autism spectrum getting ICC with a dual diagnosis, comorbid, but the secondary diagnosis cannot be a result of the autism spectrum disorder. And it's hard to kind of dice that out to figure out, is the secondary diagnosis a result of the autism spectrum diagnosis or not? What I encourage people to do is, if the child has ASD and let's say anxiety, because a lot of kids that have autism have anxiety, and they would benefit from a care coordination, you can make the referral to the intensive care coordination, and they will do an assessment to kind of figure out, are they eligible or not. But if the child only has ASD, they are not eligible. But if they have ASD and a secondary diagnosis, it gets really tricky whether they're eligible or not. And so that's why I say you should make the referral, because you need to figure out if the diagnosis other than the ASD is a result of the ASD or not. And so that's why I say make the referral and kind of go through the assessment process to figure that out.
Okay, great. So this question asked about age limit. And so for a family that is working with DCF, is there an age limit for parents to qualify for family partners?
So if the family again is working with DCF and DCF has custody, the age limit is the age limit on the child, not the parent. So it's the child up to their 20th year. So no, there's no age limit there, and it's not based on the parent age limit. I will say some of the complication is these are home-based services. So if the child is in long-term group care without a hub, doesn't have outpatient, doesn't have IHT or ICC, then they're probably most likely not going to be eligible for family partner. But if a child is in, let's say, a group home and getting ready to transition home and there's an outpatient therapist involved, yes, they're eligible for family partner. And also, I don't know if some of this question is being driven, the child needs to have a goal to reunify home. Right. If the child has an independent living goal, there would be some questions about what the goal and what the purpose is of that family partner.
Okay.
Hopefully that answers people's questions.
Yes. I think Karen who asked the question just said DCF has custody of the child.
So yes, they are eligible for a family partner. Again, the child would need to have outpatient therapist, in-home therapy, or intensive care coordination. And you could have a child, let's say a child is living with a foster family, that child is eligible for in-home therapy, is eligible for a family partner or intensive care coordination. And what the goal hopefully those, any one of those services, because I would assume the goal at some point is to reunify home, and DCF again DCF would have to give permission, but with permission from DCF, that team would work with the foster parent and the biological family. But again, DCF has to give permission and has the decision making around involving, since they have custody, around involving the biological parents.
Okay, great. So we have another question, and this is about the mobile crisis teams. Yep. And the question was, do they go to the group homes?
Yes, they do go to group homes, residential schools, any of that, and that should be those group care providers. A lot of the group homes actually have relationships with the mobile crisis teams, and they should be calling them and not taking the child to the emergency room.
Okay. So this question regarding the model that is talking about the model or the levels we were talking about master's level, bachelor's level. And so the question is the in-home behavioral agencies required to provide the two-prong provider model? I think this person in the past is saying that they've been in situations where the in-home behavioral has only been a bachelor's person, and then there was no therapeutic mentor, and the agency said they didn't have enough monitors to provide everyone with services. And the behavioralist in this situation was not a master's clinician. So it seems like there was maybe a lot of confusion about who needed to be in this home situation.
So for in-home behavioral, the master's level person is required, and the bachelor's level person, whether they put in that second team member, is really the family's choice. Majority of cases should have the bachelor's level person, but in some situations the family may say, I really don't want that second person. So it's really should be driven by family choice for the bachelor's level person. It should not be driven by provider availability and capacity. I mean, there are, again, to be transparent, there are some staffing shortages out there, and sometimes the services, we want to get services in and support families. And so if that's going to happen, the master's level person should be the first. You cannot open a case without the master's level person involved. That is a requirement. The bachelor's level person should be, again, driven by family choice. And if the family wants it, then they should be there to support the family.
So when a family or someone involved with the family in some type of advocacy role feels that there's an issue going on, where do they go with that?
So I would encourage people, again, first step should be to the team to say, well, there's some challenges here. What is right? What is wrong? And then if you aren't getting an answer that really is sufficient, then I would encourage you to go to the program director of the organization, the agency's program director. And then the other line of step is, all these kids, they have managed care companies, and most people actually don't think to call their insurance company when there's a problem. Is you should be calling the managed, whoever is the managed care or ACO organization for that child, you should be calling them and letting them know. I mean, a lot of people, and I'll say in my own commercial insurance, never think to file a complaint with their insurance company, and that is your right as a card holder or a member of that insurance company, is to file a complaint with the insurance company. So I would tell you to go there. And there are specific, within all of the managed care or MassHealth Managed Care ACO, accountable care organizations and managed care organizations, there are very specific CBHI kind of managers. You're most likely not going to get to them. You may at some point, but it'll go into their customer service department, and then that complaint or that concern will go over to their CBHI team, so that CBHI team can follow up with that provider. But again, I think I would just say is start at the organization level, out of respect for the organization and the staff people there. Talk to the staff that are directly involved with your team, and then go to the program director, and then go to, if you're still having challenges, is to go to the insurance company. I mean, and ultimately, if you really feel that no one is responding, ultimately you can come to MassHealth and to CBHI, to myself, Laura Conrad. You can come to us. I think there's a CBHI mailbox. I actually don't have that. But I also can pass along to Pat to my email address.
And we can send it out.
And we can send it. But that should be the last step, really, is I mean, just for me too, out of respect for everybody, you should really start at the local level first.
And I think in many of those situations, if you don't go through the steps, then you have questions that would cause you to have to go back. So it's just better to get all the information.
Sometimes, misunderstanding, miscommunications, and things can get resolved, especially when program directors get involved. Things can get resolved sooner and quicker at a program director than waiting to go up the steps.
So now we have a question about the composition of the Wraparound team.
Yeah.
And the question is, are school district representatives members of the Wraparound team?
They can be. It's really up to the family to decide who they want on their team. So if the family wants a teacher on the team or a guidance counselor on the team, then yes, they would reach out to that school district or that teacher or guidance counselor and invite them to be part of the team. You could have an outpatient therapist part of the team. You could have, your neighbor next door. You could have your coach or your priest, whoever, to be part of the team. It's really up to, or an advocate. It's up to the family to say who's part of the team. And also encourage, you could have a PCP or a nurse that's at the primary care office to be part of the team. But the family needs to give permission. And sometimes there's some challenges with the school. And so we encourage that families and then the Wraparound team include the school, because that's such an important piece of kids' lives. And so, and it may be that schools are hard to get to at a meeting because it is a time commitment. And so is there a call-in? They could call into the meeting, or they could write kind of a write-up and pass on to the information, but there should be communication and they should be included as part of that team.
Great, thank you. So we have another question about workforce issues, which we all know is a big problem. And it says, so 2 points I'd like to ask. The first is, what is being done about the lack of in-home therapists for children, especially those unable to leave the home? So are there any maybe initiatives or things that are being done in the state?
Yeah, so we have quite a few initiatives actually that are going on. Is, if for in-home therapy, it's a very intensive model, and working with a really could be very challenging situations, and they're a really young workforce. And so we really looked to make the model actually better and put a lot of information out there. We've developed an in-home therapy practice profile that really talks about kind of the best practice of the model, and what it looks like. And because how intense the service is, we see a high rate of turnover within the model. So if we can support people better, give them better training, give them better supervision, which that's what this in-home therapy practice profile does, give them better support and training, that they would stick around longer. So we've developed that. We have 2 different supervision initiatives out there to help to train and support people on providing better supervision. And the other thing, we have a couple other things. One is we piloted last year, and it's going again this year, and it's small, but it's still something working with the schools, the master's level schools, for an integrative seminar to help support the students that are actually getting their master's degree, and to help guide them and support them in going into CBHI. We have an integrative seminar, so we started to work with some of the graduate schools. We also have an initiative where if we will pay for people to get independently licensed. So you have to provide a little bit of time back and some time into the service, and we will help. We have some financial incentives to pay for licensing and testing and test prep for that. But it is a challenge, and I will say it's not just a challenge for CBHI, it's a challenge across the whole system. And it's a challenge not just for Massachusetts, it's happening nationwide. As the economy gets better, the less likely people go into these services, go into this workforce. So it is something we're addressing and looking at, but we know it's a challenge, and part of our thinking is, how do we get people to stay in the field or stay in their jobs longer? So that's what we're doing, some different initiatives around.
Great. And I know I've heard you say a little bit before, refer to maybe things family can do when they think about the services they need, like time of the day that they, maybe you could speak a little bit about some of those tips for families.
Yeah, I think when people are calling for IHT or whatever, especially IHT and TM, is to really think about what time of day is really works for you all and would be helpful for a therapist to come. You know, depending on the age of your child, I mean, after school or weekends, because sometimes a lot of IHT, I mean, I by no ways encouraging people to pull their children out of school, and you should not be pulling your children out of school for therapy. But there are some more flexible in the hours of, 9 to 3, because a lot of kids are in school. But for families that have younger age kids, to say that, we're available, or I'm not working, or my child is home on Wednesdays at 10 o'clock in the morning, and there's some more availability. And also to talk about some needs around the weekend. The other thing I would say is, for therapeutic mentoring, we hear a lot of families that request specific genders. Mm-hmm. And it can become a challenge, especially requesting male therapeutic mentors. And we encourage people to really think about is, why do you want a male? It's a therapeutic, I understand some of it, but it is a therapeutic support. And if you could get the service today with a female and provides the same amount of therapeutic support that a male would, I would encourage people to really think openly about kind of, do you really need a specific gender or not? And what's the criteria behind why you want a male or a female in some ways, because there's some more availability for therapeutic mentors around genders, around females.
So then next, so just to follow up on the master's level, someone was saying, do they have to have their master's in hand to qualify as master's level, or if they're in a master's program, are they allowed to go out?
So there's a master's level staff. You have to be, you could have some agencies have interns that are working there that are in their second year of social work school that may be providing some of this support, but that is few and far between. Those are really small numbers of who those second year interns are. But to provide the master's level support, you need to have really majority of the workforce, I will say probably 98%, have masters in hand. The bachelor's level people is where you see, again, bachelor's level people or people that could be getting their master's degree in their first year. You see them in the bachelor's role. I think what happens a lot, I will be really honest, is we're all guilty of it, is, and it's confusing, is families have people coming into their home and there's some misunderstanding of who's in what role and understanding their role and their titles, and it gets confusing, especially when you have a lot of people coming into your home, is understanding who's doing what. So I think there becomes sometimes some misunderstanding of who's in what role.
Right. Okay, great. So then another question we had was, what is the next step of in-home, if in-home services are not working?
So I think that's a complicated answer. I would really, it depends on what in-home services you have. There are agencies are required to have a psychiatrist on as a consulting psychiatrist. We encourage teams where families are struggling and the child is struggling to bring the team together and to bring in their consulting psychiatrist to really talk about the goals and the trajectory and what needs to change, because sometimes there's a misunderstanding of the diagnosis and how that's impacting and how the treatment is impacting the diagnosis. So we encourage that. I will say, there is I think it's smaller than people think. There's a small percent of kids out there that have, a serious mental health issue, underlying issue that's going to go long term. There's some ability to apply for DMH services or depending DDS services or other state agencies. But that's not the first step. I really don't encourage people to do that. There's a whole eligibility process, and actually CBHI serves, 10 times more kids than they do. I really encourage for CBHI services for that team to get back together and to really think about what is off, what are the missteps, and what can we do differently? Because sometimes we hear, especially IHT, if a kid in a family is struggling, but the IHT team is going out once a week for like 2 hours. So if you increase the intensity of IHT, let's say 3 days a week for 2 hours each day, would that help the family and the child with a better trajectory and better outcomes? I think it's a difficult question to ask of what happens. And I think the team needs to come together, and again, including the school district also, because that's another question, is if the child is struggling at home, are they also struggling in school, or maybe not? Maybe they're struggling in school and not at home, and that's another reason why to include the school district as part of the team, to think about if something is working at school, well, how can we learn from that to bring that into the home of what's working at school, or vice versa. So it really should be a team decision. Hospitalization is it's a really tough decision to make for a child and for a family, and as a parent, I think it's a hard decision to make, and really it's not. I mean, that's short term. Hospitalization average length of stay is 7-8 days, and for CBAD it's 11-10 days, so it's not a long-term solution. So families shouldn't be looking at hospitalization as a long-term solution. So
great. So another question I have is, what type of follow-up does CBHI or MassHealth have with families to assess, the quality of the services that have been provided? And so I guess they're asking, is there some type of survey of families, anonymous, or other types of things?
Yeah. So I will say for all provider agencies have family satisfaction surveys, and so they all do them on their own. And for MassHealth, for the intensive care coordination service, we have what we call the Wraparound Fidelity Index, which is in the TOM, the Team Observation Method, which is families are randomly selected to be part of that, and I think there's over 600 families typically a year that are part of that, and so we survey the family to get feedback about kind of the wraparound process and how it worked, and was the family included, who was on the team, and so we do that annually for the intensive care coordination model.
Okay, great. So this question just came in, and it says a little bit back to when you were talking about reconvening a team and talking about it. It's asking, what do you do if you feel that the team is not the right fit for you, that it's not working? Are you allowed to discontinue your team? what do you do to report, do you have to report something regarding this issue?
So there could definitely be situations where it's just not the right fit, right? I mean, sometimes we get along with people, other times we don't. So it could be just not the right fit of the clinician, of the bachelor's level person. So in those situations, I encourage the family to have a conversation with the supervisor, the program director, to say that, it's not working, it's the right fit. And so you can then choose to decide to have a different team come in from that same organization. But as a family, so as a parent, I just want to say, these are voluntary services. So it's really your decision about whether you want the supports or not as a parent. But then once you get them, if the team isn't working, you can decide, you know what, I'm all set with this. I don't want to do this anymore. We're good. Just in general, or you can request a new team be assigned through that same organization, or you can go to another organization to say, I want to go someplace else because this isn't working. And if you feel that the service was not good, if there's that aspect of it, again, not that you need to continue the service, but again, I highly encourage you to reach out to the program director and let them know that you're terminating, but here are the reasons why, because they can't make improvements with their staff and work on skill development with the staff unless they know why. You also have the right to, again, then call the managed care insurance company and file a complaint, or let people know that, like, this wasn't what I intended, or I didn't get what we thought we were getting, and if it was poor service or poor quality, whatever, to let the insurance company know that it was poor quality.
Okay, so there is a question here. So how would an SESP, which are the surrogate educational parent program we have here, how would they seek out additional support for a group home clinician treating their surrogate student at that group home?
So I think the group home piece gets really complicated because, I mean, depending on who placed the child in the group home, whether it was the school district, whether it was DCF or DMH, there's some requirements that DCF and DMH have around whether they let outside providers, if you will, come in to work with that child. What you should be doing is having a conversation with the clinician at the group home around additional supports, and depending on, when that child is going home, is to think about what are the transition services that are going to be there when the child goes home. But I would be reaching out to the clinician at that group home to talk about what are the additional supports. In some situations, some group homes, the child could have an outpatient therapist. They could have some of these services where, it really is up to the state agents. I mean, state agencies design these programs, and some of the supports are included in the program. So we just have to be very cognizant about duplication of services. So that's why I can't really, it's hard for me to speak to that, but I would encourage you to reach out to the clinician, the social worker at that group home to figure out what additional supports. And you may say to them, what about CBHI? And to have that conversation with them.
So this question, we spoke a little bit offline earlier about language barriers in accessing CBHI services. So I think there's a couple parts to this question, and one of them has to do with looking at the MABH Access site, and they're wondering if using that site, are there interpreter services available for families through CBHI to learn about benefits? So I don't know if it'd just be that site, or is there another way that they can learn about benefits? And then from that point, how does an interpreter get involved with the family?
So all the insurance companies are required to have interpreters, or a lot of them use language access lines. So a family could call their insurance company to learn about what the benefits are. On the MassHealth website, there's actually a CBHI website that there's CBHI brochures that give a little blurb about services, and they come in some different languages. So there's one way, if you can go through the CBHI website, or you can call the insurance company, and there's a language access lines they use that have all languages available, and they would have some conversation. I mean, not very detailed, I just want to be honest, to learn about what the services are. Once you learn about kind of what the services are, once you say you go to intensive care coordination, all of our CBHI services are required to provide interpreters. The best model, best practice is to have someone that speaks the language, but that's not always an option. And so if a family is calling, sometimes there could be staff that speak that language, and there may be a wait list, or sometimes you can get the first available staff that speaks English, but they're going to offer an interpreter. But CBHI providers are required to offer an interpreter, offer the service in the language of the family. And if you aren't getting that response and people aren't offering that, again, I encourage you to call program directors as advocates to help families navigate this, and even families. And I also encourage you to call the insurance company around this to have a conversation or file a complaint, because families should not be turned away because there is no access in the language of the family. So hopefully that answers people's questions.
Great. Okay, we have a few more minutes for a couple of questions, and questions that we don't get to, we'll going to try to answer for you and provide through email answers to those questions. There is a question about what is the limitations of the ICC's ability to advocate at educational meetings.
So they are not educational advocates. I want to be real clear about that. A lot of them have had some basic trainings, but they are not educational advocates. They will help coach a family around some of their rights, but they don't know the system like an educational advocate or a surrogate educational partner, forget what exactly the terminology. They have some basic training, some of them. So I think to look for an ICC to be an ed advocate, you should not make that assumption, and I would not make that assumption. That is not their role. And sometimes what they will do is help families if they can help to some degree around the IEP process and getting kids evaluated, and helping families to kind of figure out what are the services supports a child may need. But it's a difficult process. It can be a challenging process. And if a family needs more than that, they will help a family kind of understand there are educational advocates out there and help them kind of walk through the steps of how to get one. But they are not educational advocates.
Okay. So two things maybe quickly we could touch on. One was just to clarify, with Commonwealth, for people that apply for it, some people have just put out there that there's premium assistance in the state that can help pay some of those premiums. If you just want to maybe quickly.
Yeah, I mean, there's which we didn't really talk about it because there's lots of kind of things in MassHealth. There's premium assistance, which is the ability to help pay for your either commercial insurance premium or to help pay for some of the Commonwealth, and that's another process of the premium assistance. It may not pay all of what Commonwealth costs, but it may pay for a portion, or it may pay for a portion. It really is designed to help people pay for their own commercial health insurance. Mm-hmm. So it pays for a piece of it. So there is what's called premium assistance that's out there to help people cover the cost of Commonwealth or their really commercial health insurance benefit.
Okay. All right. Well, we want to say thank you very much to Laura for coming today and sharing all of this information with us. It was extremely helpful. I'd like to remind everybody that you'll be receiving a follow-up survey, and we'd like to ask you to please complete that. It's very helpful to us going forward. So we use this information, we value and use it to provide you with the most effective and relevant material. We have two announcements which are on the slide, which are the save the dates for two of our upcoming conferences this fall. MassFamily Voices has their annual conference. It's going to be November 13th, and RTSC will be having their conference on November 27th. So stay tuned for details coming in September. Thank you very much to everyone for joining us today. Have a great day.